The third talk is from Dr. Ravul Jindal, Venous Ulcers, What is New?
Good morning, everybody. I'm going to talk about our experience in treating venous ulcers. I don't have any financial relationship to disclose. So let's know about the venous ulcers. As you know, the leg ulcers is a common chronic recurring condition. And the prevalence of the venous ulcers is around 20 per 1,000 people over 80 years, and which is quite a huge number. And as we grow older, the chances of getting a leg ulcers increases. The problem is that the re-ulceration rate at 1 year also varies from 26% to 69%. So why venous ulcer happens is either because there is a reflux, because there is a damage of the walls, or because there is an obstruction in the deeper venous system, or both things happen in the same time. So let's take an example of the 63 years old, 8 weeks history of non-healing ulcer on her shin. And she described it started after she bumped her leg on a chair and she has been dressing it herself and it's not healing. So we need to know a lot of things from her history. Is the ulcer painful, discharge, smell, surrounding skin itchiness, change in the size of the ulcer, past history of DVT or venous disease, past history of arterial diseases, is she a diabetic, autoimmune response, or autoimmune disease she has, any cancer, or any renal disease, or she is on immunosuppressants. Because all these things can cause you a leg ulcer. If you look into the venous ulcer, typically it's situated on the medial half, on the lower aspect of the leg. Normally does not involve the toes. There are associated varicose veins, pigmentation. There is status dermatitis. There are chances you can see a lot of changes in the skin in terms of lipodermatosclerosis, and sometimes you have multiple ulcers. And some patients will also give history of poor mobility and they are obese. Once we diagnose that this patient clinically has got a venous ulcer, we get a Doppler done to find that what are the status of the deep veins and the superficial veins. And then once we have made a diagnosis that it's a venous ulcer, then you treat in terms of the cellulitis if the patient has, the edema of the patient by leg elevation. We improve the mobility of the patient, that will also decrease the edema. We treat the dermatitis. We give the patients an antiplatelets and MPFF tablets. We do a bandaging, a compression bandage, and in some patients we do an endovenous treatment. Let's take up this patient who has got an extensive skin damage, a venous ulcer. The most important in this case is to give small doses of oral steroids and apply local steroids. Give this patient antihistaminics and antibiotics. We give a compression therapy. We give an ecospirin and an MPFF factor. So you can see within 4 to 5 weeks, you can heal these ulcers without doing any intervention. So compression therapy is the gold standard for venous ulcer. So that has been proven by multiple trials and by a lot of studies and by clinical practice. If you look into the progression of the treatment of this ulcer, if this ulcer size decreases in 3 weeks and less than 40%, then we must reevaluate that are we doing the right treatment or not. And if the ulcer is not healing and deteriorating, then we must look up the diagnosis or the way we are treating. Sometimes you get a recurrent venous ulcer because of the diseased skin, and this can also again get healed with compression therapy and treatment of the venous pathology behind. Another example, with an infected venous ulcer in a diseased skin, we took a wound culture, gave an antibiotics, did some local debridement, and then we just did a compression therapy. So you can see within 6 to 8 weeks, this ulcer heals up nicely. Now the role of antibiotics, people ask us. See, most of the time, if the cellulitis is localized, you don't need to use injectable antibiotics. But let's take up this example. Look into the extensive cellulitis this patient has. So normally we start these patients on injectable antibiotics along with the wound culture. And then the next picture where there is a round blue square, you can see 1 week later with the compression therapy, a huge response with injectable antibiotics. Then another week, we change it to oral antibiotics. Then another week, we stop the antibiotics. So in the last 6 weeks, we have not used any injectable or oral antibiotics, just a compression therapy, and these ulcers, they heal up. In terms of dressing agents, there is no role for hydrogen peroxide, boric acid, salts, iodines, and they are all toxic to the tissues. So what dressings to be used? There is not a single randomized controlled trial what dressings to be used, and most of the time you can get away with very simple dressing, cleaning with a saline and simple ointments along with the compression. So compression is the key. So in this case, we didn't use any ointment, any antibiotics, just a simple saline cleaning and gauze and a compression, and these ulcers, they heal up nicely. We must educate the family because patient has to look after his skin, has to exercise daily. If he's smoking, then he has to stop the smoke. And in some patients, we have to do some surgical techniques in terms of sclerotherapy, in terms of endovenous laser or radiofrequency ablation, and in some cases, a surgical excision. This is a very important technique which we use in some cases of reflux of the perforators, which could be the cause of the localized venous ulcers. What we do in these patients is, as you can see, there is a venous ulcer, and on ultrasound, there is a huge perforator at the base of the venous ulcer. So ultrasound guided, we inject a foam sclerotherapy, and you can see here on the video and ultrasound, you can see the needle is gone into the veins, and we have injected 3% STD and closed these veins and put in a 4-layer compression. Now this treatment really helps in the healing of these ulcers much faster. In some cases, we have to use skin grafts and skin substitutes. Like in this patient, we've used a pinch graft under local anesthesia. Another case where we used a skin grafts. Another case, a chronic venous ulcer. When the wound is granulating, we put in a skin graft, and these ulcers, they heal up nicely. In some patients, we have to use a dermal grafts, like in this patient where we had to use an Integra, and because the ulcer was not healing even with compression. And once you put in a dermal graft, this really helps them. And in this patient, we have used an human placental allograft, which helps us in healing of these ulcers. What do you do with highly exudative venous ulcer like this? So what we have seen in the last few years, if you just do 4-layer compression, it spoils the skin. So what we do is we use a vac on these patients with injectable antibiotics, take a culture, and put in a 4-layer compression with vacuum pump. This we have found has really given us a brilliant results in these highly exudative venous ulcers. We must prevent the recurrence in terms of take care of the skin, calf muscle exercises, treat the underlying venous disease. The Venous Association of India has published a consensus document on treatment of venous ulcers, and which has got the 6 points in terms of dietary, medical management, dressings, debridement, compression therapy, endovenous therapy, and surgical therapy. You can go through these guidelines on the internet, where a flowchart is available for the management of these venous ulcers. We are also managing a venous ulcer registry. 600 patients has been recruited up to now, and we are supposed to complete this by March 2022. But the initial result shows that average age of the patient who gets a venous ulcer in our country is 55 years. And if you look into the baseline profile, most of these patients has history of prolonged standing. And these patients, in terms of pathology, majority is reflux, but a lot of patients has got reflux and obstruction. So a lot of PTS, post-thrombotic syndrome, patients who gets a venous ulcer in our country. So in conclusion, management of venous ulcer must be multidisciplinary. Comprehensive evaluation of the patient and ulcer is required to determine the etiology and frame an appropriate management plan. And the mainstay of the treatment remains a compression therapy, along with several adjuvant treatment options in terms of medical treatment and an endovenous laser therapy and foam. Thank you.
Thank you very much, Dr. Ravul.